I'm now very honored to introduce to you Dr. Charlene Collier, who is the Medical Director of the Bureau of Maternal and Child and Infant Health, at the Mississippi State Department of Health, as well as the Director and Co-founder of the Mississippi Perinatal Quality Collaborative. She's an Associate Professor in Obstetrics and Gynecology at the University of Mississippi Medical Center. And we're really looking forward to your remarks, Charlene.
Thank you so much. I'm so humbled and honored to be a part of this, what has been really an amazing 2 days addressing health equity. And it's really an honor and a honor. Thank you, Dr. Brindes. I am also the director of our Maternal Mortality Review Committee. And knowing we were following Dr. Borders and her amazing work in Illinois, and we are really just trying to aspire to be like states like Illinois, I wanted to get at the foundation of one of our policies addressing maternal health, which really provides the why behind the PQC changes and political changes we need to achieve improved birth outcomes. So I'm going to be focusing a bit on our Maternal Mortality Review Committees and its work to build capacity to address maternal health equity. Next slide. Next slide. Okay, so a little bit about Mississippi and the maternal care outcomes and landscape. We have about 3 million people and close to 37,000 births in the state. We have 41 birthing facilities, only one academic medical center, which is a level 4 NICU, and 10 level 3 NICUs scattered across the state. From top to bottom, our state runs about 7.5 hours, depending on how fast you drive. We have about 400 OBGYNs in 36 counties out of 82, making much of Mississippi maternity care desert. There are less than 5% of births in our state attended by midwives and no birthing centers. We have one abortion provider in the state in Jackson, Mississippi, and over 65% of our births are covered by Medicaid, which is controlled by our state legislature. Mississippi is well known to have some of the poorest birth and health outcomes in the country, with the highest cesarean section rate at 38.5%, highest preterm birth rate, and highest infant mortality rate in the country, with the greatest burden of those disparities falling on Black birthing people. So it is well known, any map you've seen about health indicators tends to have Mississippi on the bottom of it. And to be clear, Mississippi serves as a clear example of the impact of racism on health in a population. Go to the next slide. So all of those maps we tend to present on birth outcomes started with these maps demonstrating the history of concentration of enslaved Black people who were denied basic provisions for human dignity for generations, followed by a particularly violent form of Jim Crow terror in the state, which did not stop at the walls of the hospital, and but shaped the way care was provided for women and birthing people in our state, and particularly was particularly dangerous and harmful to Black women like Fannie Lou Hamer, who suffered Mississippi appendectomy, as it was called, or involuntary hysterectomies, which by her estimates occurred to about 60% of women in her county of South Sunflower, which to this day has some of the highest morbidity rates. And these are not just vestiges of the past by the fact that our state flag only just removed the Confederate emblem in 2020 with resistance, demonstrating a legacy of white supremacy that still persists in both our politics and in our state. Next slide. So that is really the backdrop behind our disparities, with Black mothers having a disproportionate high rate of death in our state, but also demonstrates that all people do worse here in Mississippi because of those factors. The leading causes of death in our state are cardiovascular conditions and severe maternal hypertension, including preeclampsia. And among those two causes, Black birthing people make up 70 to 80% of those deaths. We see about half of deaths occurring within 6 weeks postpartum, but 37% occurring in that extended postpartum period when most mothers and birthing people no longer have coverage through Medicaid. And these are occurring in our hospitals and emergency departments. Next slide. Of course, it does not end with mortality. And this is our severe maternal morbidity data, demonstrating oftentimes conversations in Mississippi are very Black and white. In fact, when I moved here, data was actually presented as white and non-white, and that only recently changed. So now we finally are getting more granular data. Yes, I see faces, and that is true. That was embedded in our public health system for a very long time. So now finally removing the language and beginning to see how these impacts are hitting all birthing people of color, in particular American Indian of the Choctaw tribe within our state. But the vast majority of severe maternal morbidity events, roughly 57%, affect Black birthing people. Next slide. So the Mississippi Mortality Review Committee was established in 2017, particularly to get at better data and to begin driving change. After two failed legislative sessions, House Bill 494 created the Mortality Review Committee, providing legal protections and access to medical records. We received CDC funding in 2018 and analyzed all pregnancy-associated deaths identified within 1 year of the end of pregnancy, but really performed in-depth committee reviews of likely pregnancy-related causes. Created recommendations for states to reduce maternal mortality. And our first report was published in 2019. All of this seemed like very heroic events, things we're very proud of to get that work done for the first time with a comprehensive committee with comprehensive access to data. Next slide. But in many ways, we were already missing the mark on equity. Despite identifying major gaps in evidence-based obstetric care and creating needed recommendations, there was overly focus on the medical record as a data source. When you previously only had access to vital statistics like birth and death certificates, having a medical record became like that was the truth and the facts. And in fact, it's only one side of the story and in many ways erased the story of the birthing person. There was overrepresentation of clinicians on the committee, and recommendations then were highly clinical. And lack of patient input and family voice also was a major concern. There was also clear avoidance of discussing racism and politics as sources of disparities, then leaving out the real solutions that are needed to drive change. Next slide. So this brought us to ask the question, even in 2018 and 19, once that first report was published, is our MMRC actually equipped to address inequities and Black maternal mortality? Did we have the representation and inclusivity of committee members, or a process to recognize and eliminate personal bias and racism in that review process within our committee members? Were the data sources holistic, capture perspectives of pregnant and birthing people and families, and evaluated for racism and bias themselves? Did our committee members have knowledge about health equity, social determinants of health, and the impact of racism on underlying causes of Black maternal health inequities? And were there any awareness of Black community strengths, solutions, and scholarship in the development of recommendations? And do we in fact have the influence and authority to create policy and systems level change? Next slide. So with that, with the production of that report, we started with a specific equity committee so that equity would be at the center of our process. And it's a simple statement, but that we would have equity as a focus and set as a mission of closing these racial and socioeconomic disparities. Next slide. So I'm going to go just through the different components of our MMRC and how we're infusing equity within each of them. So within our committee representation, very specific in the legislation and our guidelines not to be terribly prescriptive about committee membership in terms of numbers and term limits, because we found that would limit who would be able to access being a member of the committee. The state typically used the process of requesting nominations from professional organizations from membership, so from ACOG or A1 or AAP, and that actually produced an overwhelming number of white members that were recommended because they were overrepresented within those professional organizations. So we allow for multiple members within roles to ensure equity and racial geographic concordance across positions. So not just having one social worker or one nurse, but making sure we have multiple opportunities for representation. And we're always recognizing and correcting gaps as regular objective of the committee, asking, is the right person at the table and can we actually answer this question? And we were glad this year to be adding patient advocates, Black community mental health workers, and domestic violence specialists to our committee just this year, and always looking for improvements. Next slide. We established the Equity Subcommittee back in 2019, and the purpose was to provide an equity framework, provide space to acknowledge and discuss the situations of structural and interpersonal racism, discrimination, not having to prove it within the confines of the case, and develop enhanced skills in interpreting and social determinants of health data. We're also able to participate in an equity pilot with the CDC and Dr. Michael Kramer using social spatial dashboards to capture community factors. Next slide. This is an example of that community vital signs where we're really trying to provide the committee some context in which where the patient lived. So we understood things like access to transportation, racial segregation, where that person lived, and so that the events of her death were really understood within her social life that she lived. Next slide. And we're committed to all of our committee members engaging in education. I want to really give credit to the CDC and the Maria team for promoting this and allowing us to learn from leaders like Dr. Rachel Hardiman about how we can infuse equity into all of our aspects of our committee. And this month just launched our Birth Equity Foundations training with the National Birth Equity Collaborative for all of our MMRC members. Next slide. In our review process, we try to humanize the birthing person. We give them a pseudonym rather than a case number or make it anonymized. And one particular thing we've always done is add all the personal factors for that person at the end of the event or the case, so that no judgment about who she was can lead the case, but rather the events could be judged themselves. We were also very glad to incorporate the CDC's Maria Committee Decision Form updated in 2020 to specifically ask about discrimination during the course of her care. Next slide. And this is just a glimpse of that new committee determinants form, which asks specifically about discrimination, structural racism, and interpersonal racism, and really found our committee definitely needed education along these factors. Next slide. We're also broadening the scope. Originally, I mentioned we were capturing cases that were considered possibly pregnancy-related, and suicide and drug overdose were added to that, but homicide wasn't. We did look at the statistics, so we saw the profound disparity with birthing people being affected predominantly within that homicide space, and now we do fully review the homicides and look for solutions within that. Next slide. One of the things I'm most proud of is the addition of Informant Interviews, which we added in 2020 with a licensed clinical social worker trained in trauma and bereavement counseling, who not only uses the informant interview to extract information or data from the surviving families, but provide resources and connections to services. And this has been truly transformational in uncovering details that were omitted from the medical record, out of hospital events, perceptions of care, experiences of discrimination, and providing a real holistic view of that person's life. Next slide. And so our influence on statewide change, our first recommendation was the extension of Medicaid in the 12 months postpartum, and the city lawmakers removed that provision just this year in 2021, citing costs. So we are already, despite the excitement around the opportunity to do this, we've already lost that shot this year, and so we're continuing to work on it for 2022. Also adding to that, promotion of policy changes to support the kind of transformative care we need, like doula payment and improved midwifery care. Next slide. And we're very proud to be using some of the funds we received from the CDC to fund the Mississippi-based Black women-led organizations to address gaps, and really seeing that the solutions are really here within the community. The Mommy program, which is led by two moms from Mississippi, are now able to provide mental health services, and have done so for over 200 mothers in our state, providing full treatment and coordinating care, a warm line, and access to a licensed therapist for many mothers, even in that delayed and extended postpartum period after they could lose coverage, being able to provide those mental health services, and working with Six Dimensions, who's led by Dr. Nikki Traverse, doing community town halls, helping to support doula services in our state. Next slide. I just want to wrap up thanking my team of amazing women who help support our MMRC and PPC, which none of us could do this work. Next slide. Thank you, and I look forward to the comments of
Thank you. Thank you so much, Charlene. You know, you've taken us on quite an adventure in looking at policy at the capital P level, where you're doing some work at the state level and also at the local level, small p, which makes such a big difference. So thank you so much for sharing that.